So let's switch to the next panel. And then I think there's an actual coffee break.
There is, that's right.
So
Right, how do we change the slides? Whilst we are getting the IT organised, I might invite my panellists to come up to join me on the stage. So good afternoon, everybody, and welcome to our, what we hope will be a bit of an interactive session this afternoon through the use of Slido. Our session is Simulation in Healthcare, Unlocking Potential to Improve Patient Safety. So as my panellists come up, I'll introduce myself. My name is Kirsty Freeman. I'm a Professor of Medicine from the University of Western Australia. So I've travelled a great way to be here with these incredible people that are joining me on the stage today. But I am the Secretary of CSAM, the Society for Simulation in Europe, and as a researcher, educator and consultant who's worked in simulation for over 20 years across 4 continents, I'm in awe of the people that join me on the stage today, and we will have the pleasure of moderating their conversations. I'll keep talking in the interest of time. No, we're multitasking here because coffee is after us. So for those of you who might be interested in simulation and it is a new concept to you, I just wanted to alert you to the fact that about 2 weeks ago, CSAM and the European Patient Safety Foundation ran a webinar to introduce people to the concept of simulation, because surprisingly, a lot of people that work within in the patient safety arena haven't really seen it in action. So if you have not had the opportunity to see that webinar, you will find it available on the EUPSF website. And that can be accessed here. So we have an exceptional panel that are representing different perspectives today from our simulation community, from local implementation to national strategies, from technical training to transformative system change. And as I mentioned, this is a collaboration, this session today, between the European Patient Safety Foundation and CSAM. And this reflects a real global movement towards evidence-based simulation practice. CSAM recently contributed leadership to the development of the Global Consensus Statement in Simulation in Healthcare, which establishes simulation as an essential patient safety intervention. And today, what you'll hear from our panellists is how they are using their evidence to translate this into local practice. But we want to know who is in the room. So, through Slido today, we would like you to go onto the QR code and see if you can help us answer some questions. So if you click on this little QR code, I'll give you a moment. And so the first question it's going to be asking you is just to work out who's in the room so our panellists can tailor their presentation and their answers to meet your needs today. We want to know what brings you here. So which describes you? Whether it be a healthcare professional, you consider yourself an industry or an innovation partner in what we do. Maybe you're representing more a government or policy perspective. I was really fortunate to have David Kelly present just then. It's a voice often not heard at conferences such as this, so thank you, David. Oh, just checking you guys can see the results here. That's fabulous. So it's nice to know who's in the room. So my next question for you is, how familiar are you with simulation? Is this something that's completely new? Or maybe this is part of your everyday work? Maybe it's a word you haven't yet learnt how to spell. Okay, so we have some people that have some experience but aren't using it regularly, which isn't uncommon, as most simulation educators are balancing many other roles and professional hats. All right, well, I think that's enough for us to work with. as we now move forward to find out who our panellists are today. So our first speaker, if I can find my notes, which is being a lot more difficult than one would expect. Our first speaker is Professor Rayner, a senior physician at the Department of Anesthesiology and Intensive Care Medicine at the TMU Clinicum. He is responsible for undergraduate medical education and simulation training in his department and works part-time at TMU Medical Education Centre on curriculum development projects. So Rayner, without further ado, over to you.
So thank you very much for the kind introduction and for the invitation. It's a great pleasure to be here today. I just want to give you a short introduction. Okay, you don't see the mouse. A short introduction on the working environment, the local implementation of the simulation training at the TUM University Hospital and the TUM School of Medicine and Health. We are very proud of our simulation center, which is the Medical Training Center, TUM. We are operating since 2014. We have around about a little more than 600 square meters of area. And we have there different simulation rooms, like you can see here, the operating theater, which can also be used as an emergency department. We have a simulated normal ward, which is depicted here, and also a small ICU part. And we have consultation rooms in our simulation center at the TUM University Hospital, where we practice patient-doctor communication and also outpatient settings. And of course, a simulation center is fully equipped with audio and video equipment, and we have dedicated debriefing rooms to debrief our scenarios. And our best news for us is that recently we got the information that we can double our area. There's another floor in the same building, which was the former library, which is now digitized. The rooms are empty, and we are currently reconstructing this second floor and are very much looking forward to open this new area in summer 27. So what kind of courses do we run in our simulation center? And our focus is undergraduate medical education. We do for our students emergency medicine courses or courses in anesthesia. But beyond this acute medicine settings, we have also some special modules which are, I think, not so common in simulation education. For example, we have a hygiene module where students learn to perform tasks in a hygienically correct manner. Simple tasks from just putting on sterile gloves to more complex tasks like depicted here, getting a probe, a sample from an MRSA patient, which is a little more complex. Then we have a ward management module focusing on communication, teamwork. It's a ward round training, getting informed consent from the patient, everything you need to know if you come your first working day on the ward and everything at the phones ring and every patient has pain and you have to manage this ward. This is simulated here. And as you all know, there's the educational principle of assessment drives learning. We also have some evaluation formats in our simulation center, the so-called OSCE format, Objective Structured Clinical Examination, where we assess the skills and the learning outcomes of these modules. And in the field of postgraduate education, we also do a lot of things. Of course, we have the classical CRM training, crisis resource management, and we have also resuscitation trainings for and emergency trainings for the doctors and nurses. Of course, postgraduate training is interprofessional at our hospital. And beyond the simulation center, we do also in situ simulation in the clinical departments, in interventional room, for example, in the neuroradiology. We have training for acute stroke management and for neonatal resuscitation and also emergency courses. Well, that's only a rough overview. We have around 500 trainings each year in our simulation center. And of course, as University Hospital, we have ongoing and past research projects which are connected to the simulation activities. But well, I'm not going into detail now because we have very limited time, I think. Thanks for the attention. And of course, I'm open for questions.
So we do have many questions, but we might leave them to the end and hear from all our speakers first, just in the interest of time. So our next speaker is Josephine de Clay, a critical care nurse in the intensive care unit who holds a faculty role at University Liège Medical Simulation Centre. She contributes to designing and researching simulation-based training, especially focusing on non-technical skills and team dynamics. She is the president of CIS Nursing and lead policy officer for ESNO. She bridges nursing practice with the European health workforce policy. Josephine.
Thank you, Christy. So yeah, I'm Josephine, critical care nurse, working in the Liège Simulation Center. I'll do a small presentation, like you said, of the center. One specificity is that we have two sites, so lots of organization. One is in situ within the university hospital, and one is really fancy with glasses, you know, parking spots and really fancy. I know that some have trouble with the parking lot spot, sorry. Normally, we'll have a small video. It's supposed to start. Is it supposed to start now? Yeah, I think so. Otherwise, it's just the hallways and stuff, so there's no worry that I can show you. It's okay, put it back. It's on the website. You can find it if you want to look at it afterwards. It's okay. Oh, so we have two sides. This is the entry of within the hospital, so it's really structured. So we have three main missions. One is education, research, and also help with other projects to put simulation as a leverage to achieve more things, both on educational and scientific. This is our team. It's quite a small team under the umbrella of Professor Gisens. We have 5 researchers and educational peers. Also, one of the good things is that we have sim technicians. I know that in Belgium, some simulation centers don't have sim tech, which is some added value because it's someone that can speak to the man, the man can do whatever you want. So it's really an added value. And also we have like development with faculty and stuff. Our main research projects are around the impact of simulation, the use of virtual reality, which is a big challenge and quite of innovation, but we know the struggle, and also clinical debriefing after critical incident, for example, or other event. This is our research partner within Belgium, but what's interesting is our research partner within Europe. So connect if you want to do some research or project or anything. What are we doing? We have technical skills, like basically, I think every simulation center. We do also a lot of with communication with patient or colleagues. Like I said, the debriefing is a big part of our job. This one I like because there's a boat. Okay, remember hospital setting? We use a lot of decontextualization simulation, which is really helping and not stressing people who take part of the simulation. It's way easier than to debrief how you order the kitchen than how you order your ED department. You know, the ego stuff, it's way easier on a boat than an ED department. This is some learning pathway that we develop and some bootcamp. Bootcamp are really the trending thing in our simulation center. It's a higher organization for the team, but for the student, it's really helpful. So they have the whole day training with labs and cadaver and stuff, and also it's a big mess, but they love it, and I'm pretty sure they learn a lot. This is part of the external catalog, and we are. You can scan the code. It's in French, but it's quite nice. It was made with the French TV, the Belgium French TV, and it's kind of an e-learning about CPR with a famous TV presenter. So this is also something that you can help and share in your center. This is our activity report, but you know, it's just numbers. They are there if you want to have it a look after. And like I said, connect if you want. This is our LinkedIn page to follow up the research, or if you want to connect on LinkedIn and have a coffee, share, because real life is better to develop project, okay?
Thank you so much, Josephine. And we might see if we can get that video to work after. Considering we have another video, we do hope we can work out the technology. Do you want to have a quick look? Yeah. And if there's anyone backstage that wants to come and help us work out, if in case the next video works. As I introduce our wonderful next speaker, Laurens.
In the Netherlands.
Oh, here we go, we got it working. So before Laurens press play, Laurens is the head of Simulation and Skills Centre at the University Medical Simulation Centre, who leads Digital United Training Concepts for Healthcare, otherwise known as Dutch, correct? In the Netherlands. He works on integrating virtual, hybrid and physical simulation modalities into healthcare pathways. And do you want to give us a bit of a briefing about what we're about to see?
No, we're just going to watch the video. Yeah, let's do that. Yeah.
Patients have to wait longer and longer to get the care they need. Our healthcare system is slowly being overwhelmed and waiting lists are growing. So we urgently need more healthcare professionals, but we lack the capacity for in-practice and on-the-job training. Meanwhile, the demand for healthcare continues to rise. Putting even more pressure on hospitals to train new professionals won't work. So what does work? Virtual, digital, and physical simulation significantly increases our capacity to train without adding pressure on clinical practice. This not only benefits the professional in training, but also their teachers and supervisors, the team that needs reinforcement, and ultimately the patient. Simulation is key, but also expensive and complex. Meet Dutch, our collaborative approach to develop the future of healthcare training in the Netherlands. We will build on top of what we already know and have, and create new resources and solutions to provide a comprehensive ecosystem that can be used effectively and everywhere. This way, we increase our ability to train new professionals, reduce the load on our hospitals, and work towards dissolving waiting lists. Want to learn more? Take a look at Dutch.technology.
I think that's it. But as I understand, a relatively large proportion of the audience is not that familiar with simulation, or at least not with sort of the backgrounds and the infrastructure required, I assume. So maybe it's important to say that this is an initiative that was started by the collective hospitals in the Netherlands. So it's a bottom-up approach in the first sense. And what we basically did was we connected simulation not immediately or not primarily to patient safety, but we connected it primarily to one of the headaches that our government is currently having. And this headache is all familiar to all of you, is about the graying of the population, staff shortages, continuing pressure on healthcare. So we said, okay, we want to work together, develop and implement new technologies. We went to the Ministry of Health. They have something in the Netherlands called the Growth Fund, which is a very money-driven, financially driven approach to improving the collective economic power of our country. And we basically said, if we can get some money from you to develop these new forms of simulation, we can increase the scope of simulation in the Netherlands beyond dedicated simulation centers, which we have in some hospitals, but most hospitals don't have access to this stuff, so that we can increase the capacity with which we can train. So it's not directly about the quality of training so much as the capacity of training. And we were rewarded with a huge amount of money that we are now in the process of spending the first third of it. And in the following 4 years, we will not only develop these technologies, but also implement them in every region of our country on top of what is already there. That's sort of the larger scope of it, I guess. Yeah.
Thank you very much, Lawrence. Our final speaker, before we open to more questions, is Dr. Julie Martin. Julie is the Clinical Director of Integration who leads the Scottish Centre for Simulation and Clinical Human Factors. She is a champion and champions transformative simulation, using simulation not only to train, but to influence and improve processes, team behaviours and system integration across all levels of healthcare. And she's probably feeling quite awkward as I'm reading out her bio. As the lead for the medical peer support, she also integrates clinical wellbeing into her simulation-driven systems approaches. Julie.
Excellent. Oh, and I'm mic'd up. I didn't know I would have the opportunity to be mic'd up like Madonna, and I'm quite excited about that. I am vertically challenged, so if I stood behind the desk, that would be an issue. So I cannot say how excited I am to be here. 20 years ago, when I started on my patient safety journey, I'd been doing simulation for about 5 years already by that stage. And the question I asked was, how do we bring the worlds of simulation, quality improvement, and patient safety together? Haven't got all the answers yet. But by being here today, thank you, Mirka and the team, I feel we're one step closer. And to be sharing the stage with these amazing people who are already doing it across the whole of Europe, it's so, so exciting. So what I'm going to do over the next 7 or 8 minutes is describe the initial steps that we've been making in Scotland to try and do that, to use simulation in a radical, different, I think, exciting way that will help a lot of you in the room. And I'm so excited that at least 40% of you, your primary interest is around quality and patient safety, although there are a lot of you with simulation interests as well. And I think that's so exciting because this is about bringing our worlds together and actually working more collaborative so we can become bigger than the sum of our parts. Because we've got a tool here that can really help you and your sector to look at those really tricky parts of the system that you feel like you've been banging your head against a brick wall for the last however many years. Simulation can help. And if we use it effectively, efficiently, it's going to really help you with some of your numbers as well, you know, in terms of exponentially really maximizing the return on our investment. So simulation-based education, it is an amazing tool. And my 3 colleagues here have talked about some real cutting edge areas where it's been used really, really well. And I think excitingly thinking about linking it to health economics, ambitiously thinking about how training can actually help with, you know, well-being, workforce development, you know, decision-making, all of these things that we know will unlock a lot of patient safety issues. But however, it can go even further. So I invite you in the next 5 minutes to really rethink simulation's purpose. And all of you be thinking, well, what are the bits of my job that are really tricky? And could simulation help here? And I would like you to think of it as a tool to transform health and care through collective understanding, insight, and learning. And we've heard this again and again this morning. This is about human connection. This is about trust. This is how about we build connections across the system. Simulation can help with that across any part of the system. And at least 50% of the work that we're doing in Scotland and NHS Forth Valley is around the social care and our partnership colleagues working. So I was really excited to hear some of our earlier presentations as well. So transformative simulation for improvement, about 15 years ago, started using it as a quality improvement tool. So actually looking at our data, thinking about where are the tricky parts of our system. And the first project I did was looking at Sepsis 6, my colleague here, who's looking at sepsis as a massive patient safety initiative. it was one of our top 5 governance priorities within my organization, and we just couldn't improve our compliance with sepsis 6. Despite us having steering groups, interest groups, champions, everything, it was just really, really tricky. So I was thinking, well, how could simulation help here? And we realized this was not an educational gap. So our gap analysis, our needs analysis, we were trying to do the wrong things. This was around creating a sense of urgency and prioritization about people coming into the ED with sepsis in an already busy, overloaded, overwhelmed department. So we practiced that bit. We practiced creating a sense of urgency around sepsis, and look at the data we got. This was over a 3-month period and something that had been stuck for about 5 years. We could not shift our sepsis 6 compliance above the 35% region. And within 3 months of running simulation programs, creating this sense of urgency, this prioritization, which we'd understood using process mapping as part of our quality improvement tools, we got full compliance with our sepsis 6. So this is maintained now for 10 years, 85% compliance with sepsis 6 within our front door of our hospital. And just by thinking about how to use simulation in a different way as an improvement tool rather than an educational tool, this was the data we started to get through. So that was about 10 years ago. However, we are now going further, and we must go further so we can use simulation for radical change. It can improve patient outcomes. It must improve patient outcomes. It can shift the balance of care. And what I mean from that is everything today we've been talking about is moving our focus from hospital-based, acute-based into community-based practice, moving upstream, preventative medicine, diagnostic error, preventing diagnostic error, thinking about actually how can we help people work within systems that prevent them from making those errors. Developing our workforce, massive scope here. How do we, one of the examples I'm going to share really shows us how to do that. But importantly, the work that you've done, I think it's so clever. How do we align it with national and organizational priorities? What are the headaches, not just our governments, but actually what are the headaches with all of the bodies that we're working with? Because otherwise you're never going to get any traction. You're never going to really get any hooks. So ordering small pieces of equipment. There I am on the left-hand side with the Zimmer, with the biggest smile on my face, because after 25 years of working in simulation, I was in a sheltered house, which is a supported accommodation for older people. And we were using simulation as a tool to unlock a really tricky part of the system around ordering small pieces of equipment. And I suddenly realized, oh my God, this is amazing. This is so powerful. This is the best thing I've ever done. I've been an ED consultant for like nearly 30 years. And I'm just like working in ED for nearly 30 years. And this is the best thing I've ever done, because this is the kind of thing that's going to make such a difference to patients. So what we did was we worked with our home care teams. They had been going into older people living in their own homes and noticing that they needed small pieces of equipment like toilet seat raisers. But once they noticed that, they had to put in a referral to our community occupational therapists. And that had a waiting list. That was taking up to 6 months for them to come out and fit them with a toilet seat raise. So we thought, well, simulation could help with this because there's a quality assured evidence-based process that shows we can do that safely. So we co-created a program with our community occupational therapists. We delivered it to our senior care officers, and then they were empowered and enabled and quality assured to be able to do that safely. Guess how much time in one tiny part of Scotland in 1 year of waiting we saved? Shout out a number, please, 1 or 2 people. How much time did we save by doing this project, 1 year of this project in the Falkirk region? Higher. Oh, first a patient story. I'll keep you on tenterhooks. It has impact on individuals. This is a lady who couldn't get up off the toilet. Now she can do it herself. She just cannot believe the difference. This is how much time we saved. 165 years of waiting for 1 year of the project. It's now been running for 3 years. It's totally maintained, so it's over 500 years of waiting now we've saved for older people who couldn't get on and off the toilet themselves. And the risks that go with that in terms of fractured neck of femur, head injury, progression of frailty syndromes, etc., etc. Your Home First. This is about shifting the balance of care. These are some of the projects that we're involved with. We had a brilliant presentation about your hospital at home. How can simulation help do this effectively, safely, developing our workforce? Even more radical, how do we get into schools? How do we use simulation around value-based recruitment, getting the right people into social care? If we do not solve the social care crisis in healthcare, we are absolutely stuffed, no matter what else we do. How can simulation help? We're going out there with kids saying, could I be a social carer? They explore motivational techniques, goal-setting techniques. They learn about who they are and what their values are. Simulation can help with that. Sim Safety Club, this is our front-facing thing that we do in Forth Valley. We run it every month. It's totally informed by our IR1 or our DATEX or our critical incident data. We're an absolute learning organization. We have people within the club who go back and feed into our different practices. Sorry, I've gone backwards. And we run 45 projects in every single part of our organization. We have an emergency response team where we respond within 48 hours. And at the moment, we've got 9 active projects. We've got a tiny team. We've got under the equivalent of 1 whole-time equivalent to do this, but we do it because we believe in it. And we're starting to get some funding now on the back of it. It's an example of some of our projects. The key thing about this, we do have a sprig, a prioritization matrix. So we have a bit of science behind it in terms of alignment with strategic priorities. What's the likelihood of gain in terms of the impact work within the organization? So we do prioritize our projects. We're really busy. But the important thing about this, as well as the prioritization matrix, is that the project is owned by the teams. It's not owned by the sim team. It's not owned by the quality team, because we have quality team members, we have safety team members, we have simulation experts, and we have clinicians on our team. The governance is really important. We sit within our quality program board who report directly into our program board. And I also present twice yearly to our board, our integrated joint board, so that we have a real clear governance structure, because this is real patient safety work. And here's just a snapshot of some of our data. I can't own all of this data because it's the teams that own the data. But in this, we have reduction in cardiac arrest numbers. We have improvement of proper escalation of our deteriorating patient. We have reduction of inappropriate insertion of urinary catheters across our whole system. And we start to have reduction in our pressure ulcers. So real harm, we're reducing it across the whole board. So reimagine simulation, guys. We've got a tool that can make a real difference. We just need to work together to develop our teams, and we will, and we are bigger than the sum of our parts. I'll just leave that with some thoughts about some of the work we're doing. Thank you very much.
We have only a few moments left, but I think we need to make the most of the brains trust in the room. So I want to open the floor to you. Does anyone have any questions for these incredible people and their programs and how you might leverage their knowledge? I'll start us off because I've got lots of questions. Lawrence, what did you have to do from a policy perspective to really get this national program up and running? And how do you make sure it's individualized for local context, even though it's a national program?
John? Yeah, thank you. Okay, so that's 2 questions, right? From a policy perspective, I think we ran into some luck. I think one thing we did, sort of a technical step we took, but one I can recommend, is that once you have a certain grassroots movement, a ground layer of support, multiple parties saying, okay, this is something that we want, this is a problem that we all have, is to collect a little bit of money from all the parts. It doesn't have to be a lot. And to hire one of these consultancy companies, even though sometimes they are very horrible and very expensive, they can help you speak in the language of the policymaker, and they can also help you get a foot in the door and get into the room, which is what we did. My board of directors and those of my colleagues in the rest of the country all contributed a little bit. That helped us a lot. Another thing is to get the storytelling right. It's very obvious if you work in healthcare that certain priorities exist: patient safety, the well-being of the individual, team performance, and so forth. But once you go up in these organizations and you end up at the governmental level, it's completely different priorities, completely different aspects that are found important or are seen as important. So it's all about getting the people on board that speak the language that they can understand. And then the second part was about how do you implement something on a national level while still adopting or adapting to specific needs. We saw this as sort of a scoping question. At what scope can you attack these issues? So we said we need to work together as a nation to have enough money to build the technology. That's a very expensive thing to do. There's only so many companies. But once it comes down to sort of implementing and the infrastructure required on sort of a local level, then our idea was to do it at a regional level. These regions in the Netherlands are not very big. There's about 1 million, 2 million people living in each region. But within these regions, they have a few hospitals, they have a few schools, one of them has a sim center. So then all the puzzle pieces are available. And our idea was that the scope needs to be small enough for them to know each other and have this sort of shared idea of, okay, this is our region, this is our problem, and we can solve it. But it needs to be big enough for all the elements to be present. And for us, that was this regional approach. I know some examples where within one hospital, sometimes these things can be solved. That's how we did it. And then the rest of the process is mostly getting the people in these hospitals, in these schools, the money and the time that they need to develop the solutions, and not some governmental agency or some group of people in an office building. That was very important for us. So they do the work, we support them to be able to do the work, we integrate it, and then we spread it out nationally with a regional approach that fits the individual region.
Thank you. Josephine, you spoke around your incredible work from a non-technical skills perspective. We often look at simulation to develop, procedural skills. What successes are you seeing from a return on investment perspective in really focusing on some of those behavioural non-technical skills?
Yeah, I would say keep it simple. We really need to answer the needs and build simulation around the needs you want to achieve. The non-technical skills, especially, focus on the boat and not the ED department. It will cost you way more money and it will be way more efficient. So I would say keep it simple in the aim of the simulation. Simulation is to test something, to experiment. You don't want to learn a new aspect on a thing when you do simulation. If you want to test a thing, it's okay, but you won't teach someone how to recognize a block from the heart or something, okay? The aims needs to be really specific and defined and known by everyone on board, and this is the trust issue. And if everyone is feeling safe, this will be amazing. That safety content is really important.
So I'm conscious of time and that coffee awaits us. So I'd like to ask our panellists just to reflect for a moment and just give some final words of wisdom to our audience in terms of what could they do when they return from this incredible meeting today to embed in their practice. So, just a little question without notice. Keep talking.
So from my perspective, as you said, as you heard, I have the focus on the undergraduate education. I would encourage you to start simulation training as early as possible, because if the young students get involved with simulation, there's also a change in culture, and then it's not so hard if they are then postgraduate.
Thank you. Julie?
Yeah, I would like to challenge each of you to set up a simulation safety club. It's easy to do. Your simulation experts will love it. The methodology is straightforward, and you will find people coming, biting your arm off. Look at the risks that you're carrying within your organization. Think about how simulation could help you. Start small. Our first one was around an insulin prescription error, and it was great. We had pharmacists, we had our safety team, we had our quality team. We suddenly had our directors, the chair of the board coming. And actually, in terms of actually giving people a solution and it being a front-facing tool that you can use, so just go out and do it. And hopefully my email will be available for any of you who would like to reach out, and we can work together to help you set it up. And then from that, you can think about how to reimagine simulation's purpose even further. Good luck.
Lawrence?
I'm not sure if this is the answer to the question you're asking, but I'm going to say it anyway.
Quiet, you're 5 seconds.
I feel like from the simulation side, it feels sometimes like we're preaching, right? Like it's a belief and not so much something that has been proven in practice. I have to say, even though I'm not the researcher in this group of people, that there is a lot of evidence that this works. But I would like to make a point that's maybe more important, is that regardless or not if the simulation itself is the reason why we see these impacts and these changes in the way people perceive their own environment and their own work, once you focus with enthusiastic healthcare professionals on the way they work and you empower them to speak about it and discuss it in a realistic setting, there's such a release of energy, such a positive change and such a positive process that the genie doesn't go back in the bottle afterwards. So even if the investment from my manager was always asking me about the impact and the cost and the benefit and so forth, even if that's not a clear-cut business case, there is still always advantage of focusing on these things. There's always a positive change coming from that, regardless of the financial benefits that I'm very heavily focused on in my talk today.
Yeah. What can I say after all those nice comments? Put the patient back in the equation. The simulation, you bring the patient without hurting the patient. What's really good is that we are a team around the patient, so you can use that during simulation. Nurses, physicians, other healthcare professionals. We are all in this together, so learn together and teach together so that we provide better care for the patient and for us, because we are all patients at the end.
So on behalf of the panel, we would like to thank Mirka for bringing us all together. I would just like to highlight, for those of you that do have an interest in simulation, one, to learn more, but also to disseminate your own work. It's wonderful to hear the success stories of others, and we want to hear yours. So if you do have work that you want to disseminate, abstracts are still open for the SIM conference that we have in Lyon next year. But in the interest of time, can you please put your hands together for our incredible panelists? And as Julie said, make the most of catching up with them as we break for coffee, but also networking this afternoon. Thank you very much. So please take a moment to stretch your legs. I believe there is coffee before we start again shortly.
Well done, guys. Well done.